Hello, everyone. My name is Dr. Ferghal Armstrong, and welcome to Lifestyle Matters. And we have with us Charmmy Chang of the Dietitian's Kitchen. And this episode is brought to you in conjunction with Careversity Health. So, Charmmy, I thought today we'd start a discussion on irritable bowel syndrome.
Mm-hmm.
So, what is irritable bowel syndrome?
Well, we call that IBS, commonly Irritable Bowel Syndrome. It is a functional bowel disorder. And also, the functional bowel disorder are diagnosed with using some symptom criteria. So, I'm going to ask you
Mhm.
how we can diagnose the IBS.
Yeah, so you said it's a functional gut disorder. So, really, that means that when you do imaging, for instance, there's no abnormality seen on CT scan or MRI scan or ultrasound scan. You might get a bit of abdominal distension, but apart from that, nothing significant. And there's certainly no abnormality in the commonly used blood tests that we would use to diagnose other gut disorders. So again, as you say, it goes back to symptoms. And so really, irritable bowel syndrome is defined as recurrent abdominal pain, at least daily for at least 3 months, associated with two or more of the following. So the pain is related to opening your bowels. There is an association with a change in the frequency of stools or a change in the consistency of stools. And these symptoms must have started at least 6 months prior. So, thinking about it, we've got recurrent abdominal pain with a certain frequency, and then we've got associated frequency and consistency of stool. So, we've got stool change, a change in the stool habit for at least 6 months. So, there are many, many conditions that can cause at least some of those symptoms, like a recurrent abdominal pain. Well, any number of diseases causes that, and a change in bowel habit. Well, I mean that can be caused by many, many things, and we'll get to that in a moment. But really, I think it's important to understand that it's the functional disorder. So it's a disorder of bowel function. What does the bowel do? Well, it basically manages our stool, amongst other things. And it's important to understand that the diagnosis of functional gut disorder needs to include not just irritable bowel syndrome, but functional constipation, functional diarrhea, functional bloating, opioid-induced constipation, and also unspecified functional disorder. So, to a certain extent, irritable bowel syndrome is a diagnosis of exclusion. So, you've got to make sure that you're not dealing with something else. So, that means then that we have red flag symptoms that would mean that we would really have to consider an alternative diagnosis. So, I mean, you see a lot of people with IBS. So, what are some of the red flag symptoms that you might see?
Well, I would say people have IBS, they usually have abdominal pain, bloating, and a
Mhm.
changing bowel habit, and also maybe nauseous as well.
Mm.
But there are other disease also have quite similar symptoms like that. For
Mhm.
example, celiac disease, or maybe will be red flag if the patient is older than 50 years old, because there
Mhm.
increased chance to have like bowel cancer, these things. So we really
Mhm.
want to make sure that they are not having celiac disease. So they usually the first thing I would check, have they screened their celiac disease yet? If not, I would definitely to refer them back to the doctor to ask for a screening.
Mm.
And also maybe like IBD, inflammatory bowel disease, will have some
Yeah.
similar symptoms as well. So we really
Yeah.
need to exclude all these other diseases first.
Yeah. That's a big important point, isn't it? That IBS is very much different from IBD. So,
Mhm.
irritable bowel syndrome is very different from inflammatory bowel disease. And
Mm,
remember, I said to you that the investigations for IBS are usually negative. Well, the investigations for inflammatory bowel disease are usually positive. So it shows up on blood tests, it shows up on colonoscopy, it can show
that's
up
right.
on imaging studies of the abdomen. So that I suppose really IBS needs to be seen in comparison with other gut disorders.
Mm,
So you've mentioned two differential diagnoses that we do need to exclude. So celiac disease and inflammatory bowel disease. I also think it's important to understand that um, we need to think about other causes of symptoms like abdominal bloating.
mm,
And so, ovarian cancer or endometriosis or, or general gynecological problems, that needs to be excluded. And I actually remember seeing a patient, a lady patient, she was in her 40s. She came in with a bit of lower abdominal bloating. And I was going to put her on, my standard treatment for irritable bowel syndrome. I thought, oh, she's a woman. Let me do a scan. Did a pelvic scan on her, and there was an very early ovarian cancer. So that always struck me, that lesson. You must consider as wide a range of differential diagnoses as possible. So I suppose another big cause of diarrhea per se is pancreatic insufficiency,
yeah.
and also we have endocrine abnormalities, in particular thyroid disease,
Hmm.
and another lower abdominal pain could be diverticular disease.
Right. And
Yeah.
also like bile salt malabsorption,
Yep, bile salt malabsorption. Now that's very rare. Now, how do we diagnose bile salt malabsorption?
but we need to exclude all these possibilities, right?
Is there a kind of a list of red flag symptoms that you would really look for when you're seeing a patient in your dietetics clinic? Do you
Mm.
do you screen for a certain set of symptoms to reassure yourself that we're dealing just with an irritable bowel syndrome?
Um, so a dietitian would not diagnose about IBS.
Yeah.
But what I would do is when a patient present to the clinic and if they report to me they have certain symptoms related to the gut, that most important thing I have to note down what kind of symptoms they have. And dietitian is very often to use a chart, and it's really important. This chart is called the Bristol's stool chart, and
Hmm.
we show this chart to our patients and want to ask them like which types of stool they have and the frequency as well. And this really gives us a good idea of what's going on. Are they having diarrhea or actually is constipation? And then we also take a diet history and then we'll ask for the nutritional impact symptoms. That will be, for example, um, loss of appetite or bowel open frequency increased, these certain things. And then
Hmm.
and then after that, all these, then we might have some idea. Maybe this patient also suddenly lose some weight. So weight loss in a short term is definitely a red
Hmm.
flag for us. And
Hmm.
also changing bowel habits, like for
Hmm.
example, suddenly have diarrhea or constipated, and we will note
Hmm.
that down. And then after we gather all this information, then we might rule out something, and we might think about possible this patient might have. Maybe it sounds like a celiac disease, or maybe it sounds like a IBS. And what we're
Hmm.
going to do is we write a letter back to the GP and ask for another investigation.
Yeah, yeah. So a dietitian wouldn't necessarily make a diagnosis, but certainly the dietitian would be aware of the need to have a chat with a patient, take a history from a patient, and then come to a conclusion that maybe this is not typical of just irritable bowel syndrome, and then refer it back to a diagnostician, such as a GP or a specialist, to effectively do more testing. I mean,
That's
when
right.
I think of the core symptoms of of irritable bowel syndrome, as I've said earlier, it's other types of bowel disease. So I'm looking for my red flags. I'm looking for bleeding, mucus change in bowel habit, um, a family history,
Mm,
fever, nighttime diarrhea. People with stress tend not to get nighttime diarrhea. Nighttime diarrhea that actually wakes you up in the middle of the night. That for me is a product of an organic pathology. Bleeding, as I've mentioned, but also the consequences of bleeding, which is anemia,
Mm.
And vomiting, irritable bowel syndrome, you mentioned earlier on that it can cause nausea, but it's very rare, I would argue. In fact, it's just
Mm.
not, it's not possible even, for someone with a diagnosis of irritable bowel syndrome to
Well,
actually have
no,
consistent
actually, no.
vomiting.
I wasn't saying that when they present nauseous, they might have IBS. If they have nauseous, I'm gonna rule out that because
Yeah,
I think it is not a common symptoms that people have IBS.
exactly.
Yeah.
Yeah. So no, so nausea and vomiting for me rules out a diet in
Mm,
conjunction with the recurrent abdominal pain and the change in stool frequency or the change in stool consistency.
that's right.
Um, that's not compatible with IBS. But the Bristol stool chart that you were alluding to, it's got these lovely definitions of stool, which is sometimes challenging to talk about. I'm amazed that someone actually worked out how to classify the consistency of stool. Um, can you talk us through the gradient of the Bristol stool chart?
Yes, we use all the time.
Tell us all about it.
Yeah, so the Bristol stool chart, we have seven types of different texture of the stool. So the type one, I would describe is like a rabbit poo,
Yeah,
rabbit poop, and then it's like a single. It's broken down into small little pieces. So it's
yeah,
and also it's very hard and lumpy.
yeah. So
Yeah,
hard pellets.
hard pellets, yes. And then the
Yeah,
type two was still like a pellet, but they start sticking together, right?
right.
And
So
then a
mushy peas.
mushy piece, not that soft, they're still quite hard and lumpy.
Yeah.
Yeah. And but they start turning looking like a sausage. We call that sausage. And a
Right.
type three is like a sausage shape, but with the
Yeah.
crack on the surface.
Right.
Well, the
Cracks in the
type
surface.
four, sorry.
So cracks in the surface means a sausage with cracks in it means it's a type three stool. Yeah.
Yeah. And
Right. Okay.
then type four will be what we call that ideal or the best one or the really uh, beautiful banana shape. We call that. It's
Yeah.
like a smooth sausage.
Right.
Yes, smooth sausage, no crack on it. That's what we're looking
Right.
for. We want to achieve that. And then
Right.
the type five is start getting a little bit too wet.
Yeah.
So it will also break down into smaller pieces when it's too wet. And then
Yeah.
when we get to type six or seven, we will call that is like diarrhea because they cannot form into a shape. They are actually in a liquid form.
Yeah.
Hmm.
Hmm. Now, I mean, as embarrassing as it is to discuss this, it's really important to actually understand the your stool because remember the diagnosis of IBS in part depends on a change in the consistency of your stool. And if you don't understand what your consistency is, how can you make a diagnosis of IBS? And the other thing is, that blood in the stool, rectal bleeding, blood in the stool. I often ask people, is there any blood? And they say they don't look. Well, I think it's really important that you do look at your stools because if you do have blood in your stool, I think it's important to actually identify that and seek medical help. So you mentioned earlier on the age of 50. When we're thinking about the diagnosis of IBS, why is 50 important?
Yes, just because people, when they are older than 50, there's a significant increased risk of getting bowel cancer. So it's really
Yeah,
important to ask them a question: have they get any screening for bowel cancer
yeah,
regularly? Yeah, particularly
yeah.
for older than 50. Yeah.
Now, very briefly, how do you think we should be treating irritable bowel syndrome?
How do we treat it? There's
Yeah,
a lot of therapeutic method to treat IBS. Well,
mhm,
unfortunately, this functional bowel disorder can't be treated, but what we can do is try our best to manage the symptoms. Yeah,
mm,
so there's a lot of therapeutic methods to
yeah,
help to assist to manage the symptoms. One of the very uh, people may heard about it is like a FODMAP. a low FODMAP diet. That's what we
Mm.
do a lot as a dietitian, to use the low FODMAP diet to help people to manage the symptoms.
As a GP, I see a little bit of irritable bowel syndrome, and for me, there's basically three things that I do when I make the diagnosis. One, I put them on an antispasmodic
Mhm.
agent, something like peppermint or buscopan or something like that. Then I put them onto fiber, which is something like Metamucil, and then I refer them to the dietitian. Now, obviously, it's a lot more it's a lot more complicated than that. But from the point of view of a dietitian, are there any medications that you shouldn't be using for the management of irritable bowel syndrome, or are you happy for us to use any medication we want?
It's really have to be patient-centered. If the
Yeah,
medication is helping them to manage the symptoms and they
mm,
are happy to take the medication, then of course go for it. And
yeah,
then once they have diagnosis with the IBS, and when they referred back to the dietitians, we try to help from a dietary perspective, teaching them how to just manage the symptoms by choosing the right things, the right amount of things to eat.
mm. So it's really quite encouraging then, isn't it, to hear the message that purely with changes to one's diet, it is possible to manage the symptoms of irritable bowel syndrome. And
Yeah.
I think it's also important to understand that there's no cure for this, but we can manage the symptoms. So very briefly, what's the main dietary intervention for the IBS and how would you describe it?
So the main intervention for assisting to manage the IBS symptoms will be the low FODMAP diet. Yeah.
Yeah. And how would you summarize that in one sentence?
Yeah. So, well, people heard about FODMAP, but they don't know what is FODMAP. And
Yeah.
it's actually all about fibers.
Yeah.
So
Yeah.
different types of fiber, and FODMAP is it stands for fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. These are
Yeah.
actually carbohydrate, and they are fibers, and we sometimes call that they are sugars. So they are
Yeah.
fermentable in our gut.
So really, if you had to summarize FODMAP, it's or low FODMAP
Mm.
diet, it's really altering the fiber content of your food that ultimately gets into the colon where it may or may not be digested. That's really what we're looking at, isn't it?
That's right, correct.
All right. Well, I want to thank you for your time today, Charmy. I appreciate your expertise on this subject, and I really look forward to speaking with you again very soon. Now, at that point, we will go deeper into a low FODMAP
FODMAP
diet.
sounds good.
For today, thanks very much, Charmy.
You're welcome.
That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Lifestyle Matters.